Good evening, everyone. Biliary tract cancer remain among the most aggressive yet under-discussed malignancies, with survival outcomes lagging far behind advances in oncology. Today's panel, Closing the Survival Gap, Why Biliary Tract Cancers Need Urgent Attention, an initiative of Voice of Healthcare and supported by Servier, brings together clinical, patient, and policy perspective to examine why this gap persists and what must urgently change to improve outcomes for patients across India. Join me in welcoming our panelists for today, Dr. Sushant Mittal, Director, Action Cancer Hospital, Delhi. Welcome, Dr. Sushant.
Thank you. Good evening, everyone. Thank you for such a warm welcome. Thank you so much.
Thank you. Dr. Prasad Narayanan, Lead Consultant, Medical and Hemato-Oncology, Manipal Hospital, Yelahanka. Welcome, Dr. Prasad.
Good evening. Thank you.
Dr. N. Aditya Murali, Senior Consultant, Medical and Hemato-Oncology, SCG Hospital. Welcome, Dr. Aditya. Dimple Parmar, Founder and CEO, ZenOnco. Welcome, Dimple.
Thank you so much.
Dr. K. Madan Gopal, Senior Health Sector Expert, former Senior Consultant, NITI Aayog, Advisor, Public Health Administration, National Health System Resource Center, Government of India. Welcome, Dr. Madan. So my first question is for Dr. Sushant. Biliary tract cancers are often diagnosed at an advanced stage. From a clinician and institutional leadership perspective, what are the biggest reasons behind delayed diagnosis and poor survival outcomes in India?
So, as we all know, most of us have at some point of life, we have acidity, gas, dyspepsia, fullness in stomach, and we take few over-the-counter drugs like pantoprazole or ranitidines or digenes and enos and all those things we keep taking and we get relieved. Unfortunately, these are the sign and symptom for biliary tract cancers also. So these are missed because patients keep taking all these medicines and get relief for some time, and then down the line, suddenly it appears that they have developed jaundice, they have now abdominal pain, they have a mass which is palpable in the abdomen. So they come later to our OPDs, they get an ultrasound done, and then it is diagnosed that they have obstruction, they have jaundice, and they are vomiting. So this is one of the most common causes. Another is that asymptomatic gallstones, which are not hampering, which are not affecting the quality of life. Suddenly, in 10, 15 years, they are under observation and then they suddenly become malignant. So these are the two main causes why we are still struggling to diagnose these biliary tract cancers at an early stage.
Right. I think vague symptoms and presenting late. These are the main reasons behind it. Rightly said, sir. Dr. Prasad, treatment options for biliary tract cancers have evolved, especially with targeted therapies and chemotherapies. So, how has the treatment landscape changed in recent years, and are these advances realistically accessible to most of the Indian patients?
Yeah, I think this is a very good question. Whenever we talk about any cancer, the questions are whether the treatment outcomes are changed and whether the treatment options have evolved. I think this is one group of cancers where there has been a tremendous change in the way we approach these cancers, and the outcomes have improved in the last decade or so. So I would speak specifically about the cancers which present with advanced disease, because it is out of scope of this discussion to go with the advances in early stage disease, where newer techniques of surgery, newer techniques of radiation have actually made an impact. So when we talk about the cancers which present in late stage disease with biliary tract, that is the scope of discussion here. I think that landscape has changed. If you see the approvals in the last one decade or so, there has been an immense improvement in the knowledge about the biology of these cancers. So we now know that there is these cancers have got a specific molecular subtype in many of the situations, And newer treatments like immunotherapy, targeted therapy, in along with chemotherapy, have actually made their outcomes better without increasing the side effects. To put some of this in perspective, like there have been approvals of immunotherapy. These immunotherapy drugs are now available in India since last 5 years or so, and we have now even biosimilar immunotherapy drugs which are available, which have made the cost and accessibility towards a large population of patients. And in biliary tract cancers, they have made a huge difference. Other thing which is other some medical jargon, if I can say, like we test the biopsy of these patients for some markers which are like microsatellite instability, NTRK fusions, HER2 amplification, FGFR2 fusions, IDH1 inhibitors, whether they are useful in this patient. So basically, when we say all this, it appears as if these are not routine. This is just for theory, but that is not true. These are done in our clinics, our hospitals, in our practice on a regular basis, and many patients are treated on a daily basis with these newer therapies, and the outcome is better. Now, when we talk about these treatments, the next thing which comes to the discussion point is what percent of the patients are affordable to this. That is a million-dollar question, actually. So the affordability is a question, the accessibility is a question, because these patients are not most some of them don't even have access, and there is even lack of awareness. So the World Cancer Day theme is united by unique. I would say that these are a unique group of cancers where, unless we unite as a community, the care providers, the people who spread the information, the regulators, we will not be able to give the desired kind of outcomes to our patients.
Rightly said. More we know about the disease, its biology and molecular signatures, definitely we can target the cancers better. And Dr. Aditya, biliary tract cancers are really biologically, complex and heterogeneous. So, as we have discussed, that molecular profiling has become very important in these cancers today. So, should CGP, that is comprehensive genomic testing, or profiling, become a standard of care in India? Dr. Aditya, can you hear me? I think there's some network issue. I can go to the next question. So my next question is for Dimple. Dimple, you are from the caregiving end, like you have been seeing patients and are supporting them in their emotional and cancer journey. So what are the emotional, psychological, and practical challenges families face when dealing with a rare and aggressive cancer like breast cancer?
Right.
Dr. Manisha, sorry.
Yeah, please go ahead, Dr. Aditya.
No, I just got cut off in the previous
Yes.
question. Dr. Manisha, I can take that question or I can wait for my turn again.
Dr. Aditya, you can take up that question, because I think it is syncing with what Dr. Prasad discussed, and I think we should specifically know that, molecular profiling, why is it important, and whether we should make the, comprehensive genomic profiling our standard care for cancers today.
So I think one of the points which I would like to make over here is that with a disease like biliary tract cancer, we don't get too many chances. The proportion of patients who drop off from first line treatment to the second line treatment or third, it is almost like a calamitous drop over here. So I think it's absolutely critical that we get it right the first time. So it's not, we the outlook should be to try and get the best possible care at the very first line of treatment, and towards that end getting a comprehensive genomic profiling for every single patient with advanced biliary tract cancer is the need of the day. uh, Again, to echo what Dr. Prasad said, the affordability, the accessibility is probably a different discussion. Having said that, at least the outlook should be, we have to test and test. Only when we test will we know what can potentially be corrected and how we can potentially improve outcomes.
Right, right. I also believe that that should be done to treat cancers in a better way and to understand the disease. So let's go to Dimple now. Dimple, I have been asking you about the emotional support, patients or their caregivers required during the cancer journey first thing.
Right. Thank you so much. And from a caregiver perspective, as well as from now seeing the patients, because we also started a cancer hospital in Varanasi, which is tier 2 city in India, in UP. I can also speak from the experience of patients that we are seeing here. So I see that it's very, especially BTC is very difficult cancer because it's rare and aggressive, and families are not prepared what is going to come next. And when they hear the diagnosis, they initially think that it's probably jaundice or something else, but when they get to know that no, it's something which is much more bigger and difficult, it's a very a huge emotional shock for them, because suddenly it's told that it's advanced cancer. And in maximum cases what we see here, in patients, in almost 80-90% cases, surgery is not even an option. So patients directly move to chemotherapy, or even before that they need to go through a stenting or something, PTBD, ERCP, so that first their body gets stabilized, their parameters are stable, bilirubin comes down, and then only the treatment can be started. So it all planning can be very taxing and very challenging for the families to hear. Secondly, there is a lot of psychological distress, because it's not a very common cancer type. Like we hear about breast cancer, cervical cancer, mouth cancer, but when it comes to gallbladder or BTCs, it's not very commonly we hear. So patient often they find themselves in very lonely or isolation kind of phase, because they don't have any support group, they don't know whom to speak to, there is no as such communities around it. And in most of the cases, it's what we see here in Varanasi, it's very late stage diagnosis, where the even the survival chances are very very low. So hearing all of this, suddenly it's very difficult for them. And then coming to the treatment options, different doctors, finding the right specialist. I mean, we are in Varanasi, the hospital that we have here, and then people come from tier 3 and tier 4 also. So for them it's even more confusing, and the financial toxicity becomes a very challenging. Before even they come to chemotherapy phase, even the pre-chemo phase is where all the money gets exhausted. So we see that people are mostly, they are very burnt out, managing decisions emotionally. Going through this entire phase is very very challenging. So and when it comes to tier 2, even the financial toxicity is a bigger challenge that we see, that where they have to see that whether should we at all go through the treatment phase, or we just stop it right here, because we may not be able to go through the entire journey together. And mostly patients are in the age group of 50 plus is what we have seen. Apparently gallbladder cancer is not that rare here in UP is what we have seen. So, and people often tend to drop out also from the treatment, so it's a lot to take in for them. Yeah.
I think if they're presenting late and at advanced stages, the treatment becomes more and more expensive and complex as well in survival cases. So that is why I think the priority around awareness and around diagnosis becomes really important. So my next question is for Dr. Gopal, that biliary tract cancers, what we feel is that they don't receive the same public attention as other major cancers. From a public health and policy standpoint, why do certain cancers remain under prioritized, and how does that affect the survival outcome?
Okay, thank you. Am I audible?
Yes.
Yes. Okay, thanks. One of the important things important question which you have raised, as compared to breast, cervical, and the oral cancers, the biliary tract cancers, they sit on a blind spot. That means they are having a lower public visibility, as it involves complex diagnosis, and the system is also having limited readiness compared to the other cancers. Apart from that, this under prioritization of this cancer, it results in late diagnosis, which is culminating into fragmented care, as has been echoed by my previous speakers. And as a result, the experience which Dimple has shared, it is the catastrophic high out-of-pocket expenses which is there, and it will lower the chance of survival of that patient because the patient is presenting late. But Why this cancer is under prioritized, why it remains under prioritized, we should understand that. Because many of the patients and the providers, even the frontline providers, may not suspect the biliary tract cancers as early symptoms mimic gallstone disease, as mentioned by my previous speaker. That means just a heartburn, acidity, so that the proton pump inhibitors and other thing, then the patient is happy. And the patient usually land when the symptoms of jaundice occurs and there is some obstruction is there. Apart from that, the current program which we are having, the screening focus rightly on high burden cancer, that is cervix, breast, and the oral cancer. But the biliary tract cancer lacks an easy screening test because we don't have a screening test which can easily detect this thing, except the symptomatic scoring and that mechanism which is there. Besides that, the diagnostic complexity and the pathway delays, which is resulted into the less prioritization of this, because early detection needs timely imaging, endoscopy, ERC procedures, and sometimes molecular testing, which are often not available in the in the public health system. We have around I will only talk about the public health system. We have around 730 odd district hospitals which are tertiary level institutions, and around 60 plus your medical colleges in the public sector. But you see that where, when since as the diagnostic complexity and the pathway is very difficult, how many of the facilities are available where we can timely detect this biliary tract cancer? Apart from that, one of the important things which have been echoed in many forums is the undercounting and the weak visibility of the data. Data is not there. Apart from that, the registers which you are maintaining and the routine reporting mechanisms, the the the, the reporting of the biliary tract cancers, let's get very when it gets very less programmatic attention. Apart from that, we do have high cost of advanced diagnostics, surgery, systemic therapies, and supportive care, which deters this early and continuous treatment. Apart from that, if you look at the geographic spread of the institution which we are having and the diagnostic capacities which we are having, there is a geographic inequity. You see that how the high quality hepatobiliary surgery and oncology teams are concentrated in only the metro city. That if you talk about them, they are concentrated to tier one cities or and in some places tier two as well. This results in referral delays, which can result in worsening of the presentations also. However, we see that how it can worsen the survival link because the delayed suspicion, late referral, and the unresectable metastatic disease can, at the time of the diagnosis, which will result into a poor prognosis kind of thing. Besides that, we usually miss this curative window. The curative outcomes, they definitely depend on heavily on the operable disease and the specialized surgery, which we usually listen. Without MDT care, the patient may get incomplete workup and non-standard sequences, which can result in the poor survival of the patient. Apart from that, though we do have a daycare cancer center wherein the continuum of care has been focused, but still the poor continuity of care results in financial distress and travel burden cost drop. Though we are trying to address this area of issue in the form of commissioning of the daycare cancer center, which acts as a spoke for the hubs, which are the tertiary care institution. But we can see that if a cancer is not visible in a policy, it becomes invisible in the pathways, and the patient reaches the system very too late. I stop here. I will take the next question when my turn comes again. Thank you.
Dr. Sushant, are you there? Please join in. Yes, Dr. Sushant. So my next question is for you, Dr. Sushant, that what do you think that we need certain, I think, systemic changes, whether screening protocol, referral pathways, or multidisciplinary care, which out of this could significantly improve early detection and survival rate for biliary tract cancers?
So, as I've always told in my previous talks and in my awareness camp, that all hospitals nowadays have executive health checkups. One should get those health checkups done once a year. They not only include blood tests such as CBC, LFT, KFT, and vitamin D and B12. From LFTs, we can pick up the jaundice and everything. But a routine ultrasound abdomen, mammographies, and all those things are done. So, routine ultrasound abdomen will help us to pick if there's anything which is growing in the gallbladder, if there's anything suspicious in the gallbladder or in the biliary tract. That can help us to pick, because majority of these patients, as I told you, are asymptomatic or have dyspepsia. So this is the way in which we can pick up at an early stage. And if early stage are picked up, definitely the prognosis improves.
Right. I think integrating it with the annual health checkup is a good way, and picking up the jaundice, whether it is through LFT or through ultrasound, any mass which is developing, is another way of picking it up. So, Dr. Prasad, clinical trials are critical in improving outcomes in rare cancer. How can India strengthen participation in, say, biliary tract cancer focused trials, and what barriers currently prevent wider improvement?
I think this is a very important discussion point. When you heard from Dimple and Dr. Madan, actually, we understand that there is a possibility, right? This is not being a rare cancer and concentrated in certain areas. It itself is an opportunity. Why it is like that? I mean, we always, when 10 years, 20 years back also, we were talking about the Gangetic belt being the area where we see more of gallbladder disorders, and we still don't have authentic data to say why it is so. So whenever there is an issue which is a difficult one, there is an opportunity as well. But I think if India cannot give this answer, I don't think anybody else can give, because even if the cancer is rare, because of the overall population that we have and the kind of public-private partnerships which are happening these days, it is very much possible that we can actually address some of these questions in clinical trials in partnership. So, what are the issues when we talk? One could be that the accessibility. So, it is not that these treatments are inaccessible. Now, the oncology centers, as we discussed by the previous speakers, also we have oncology centers in tier 2, tier 3 cities as well. But a large majority of complex therapies are actually concentrated in the metros. But it is not that a basic treatment or enrollment in a trial or accessibility is a problem. And there are our ICMR registry. There is the National Cancer Grid, through which lot of private as well as public hospitals are connected in oncology, and many of us report our data into these registries and contribute to them. So it is changing, and it is definitely changing towards a positive sign. So the current barriers what we have to overcome, one is the low awareness. We have heard from our previous speakers why these are non-specific. And the low awareness is not only about diagnosis, it is also about prognosis. The first person who sees this, be it a doctor or a family member or a healthcare provider in if they say that, oh, this is biliary tract cancer and there is no point in treating and the outcomes are poor, jaundice means it's end of life. All these are the problems when the patients either don't seek attention or they go to alternative therapies and then present in a late stage. Jaundice can be a presenting symptom in a stage 1 biliary tract cancer, actually. And once you find that this is a cancer which is causing jaundice, the outcome is almost it's a curable in almost 75 to 80% of patients. So basically, to give you a perspective, this I just got from the internet, is that less than 5 percentage or maybe 2 or 3 percentage of the global biliary tract cancer trials have had India as a partner, actually, which is really worrisome, actually. If you take the contribution by India to many of these trials in lung cancer or GI cancers or breast cancer, we are major contributors, actually. This is regardless of whether it's a private setup or a public setup. So we have to have systems where we are able to participate in global trials and these drugs before they become I mean, commercially available. If you are able to participate in clinical trials, the cost of treatment and the awareness and the experience of the clinicians in managing them will come down. So this is where a partnership and talks, when you get people like from different walks of cancer care together, like what is happening now, actually helps.
Right. I think that is much needed, and you have talked about Dr. Prasad cost. So let me ask Dr. Aditya that given the cost implication of advanced diagnostics as well as novel therapies, how can oncologists balance precision medicine with affordability in real world practice?
That actually is an excellent question. So basic. Am I audible?
Yes.
I think we lost Aditya, right?
Yes. Dimple, can you tell us that beyond medical treatment, please joining back? Yes, Dr.
Yeah,
Aditya.
sorry. Yeah, so that actually is an excellent question. That's a topic which should be debated on a platform like this. See, there are two aspects to innovation. On one hand, we talk about trying to bring newer treatments, newer diagnostic modalities to improve patient care. At the same time, we need to balance the innovation with the issue of accessibility as well, which is where the focus on made in India has actually made a significant difference. If you see today, the same genetic sequencing test which is done by many labs in the US or in Europe, an equal amount of sophistication and calibration is available in India as well. We have multiple Indian labs who are able to do a good amount of sequencing with the same accuracy. They are all quality accredited. The quality control sets are there good, and in terms of cost difference, they are barely one fifth or even one sixth of what it costs to do it at a foreign lab. So I mean, in terms of affordability and access, yes, made in India, Indian labs, they definitely will. They are paving the way for better access. In terms of availability of these newer drugs, especially some of the newer drugs, like ivosidenib, that's one of the new molecules for IDH mutation. Now, yes, they are patented molecules. We don't have generics for them available, and it's still under patent for now. So one of the things which China is doing to maybe get around this is coming up with their own versions of targeting these pathways. So and that's one of the issues maybe where India is lagging behind, is that although we are a country who's very good at making generic drugs, we have still not gotten onto the innovator drug bandwagon. And hopefully in the next few years, pharmaceutical companies will also invest into making sure that we are able to make the innovator drugs also. So the diagnostic test is not a problem, but the new innovator drugs, getting access to them is a bit of an issue.
Right. And Dimple, beyond medical treatment, how important are structured support systems like nutrition, guidance, mental health counseling, integrative therapies, and peer support in improving overall survival and quality of life in biliary tract patients?
Right. Yeah, I think it's extremely important because in cancer like BTC, survival is not just linked to the drugs, but is also to how well the patient can tolerate the complete treatment and the side effects that comes with the treatment. Hence, if the structured support system, if it's there, then patient can probably manage the side effects better, improve the quality of life, and also will be able to take the treatment for a longer duration of time, and hence the resulting into better outcomes. So I believe that the real difference, the how integrative therapies make is in four ways: nutritional support. So patients, they suffer from weight loss or poor appetite, liver dysfunction, and weakness. And most of the time, they don't even feel like eating at all because they can't digest it. So having a proper nutrition planning so that they can sustain the chemotherapy and the side effects that they are having. And in nutrition planning, they can go for high protein foods, easy to digest carbs like khichdi rice or oats or dalia, healthy fats in small amount, more of fruits and vegetables, soft vegetables, and avoiding oily, spicy or processed food. And having lots of hydration will help them a lot. Along with this, yoga and breathing, it helps in fatigue and anxiety management. So patients, we always see them very yeah, we see them always very frustrating in the irritation zone because they are going through a lot. So, giving them that peace around creating that calm environment, mental health and counseling is very, very important. And fear of going through the treatment itself is very high, let alone the outcome. So, I think the psychological support it helps patients in maintaining the calm environment, staying motivated, and improving adherence to the treatment as well. So in our setting, we ZenOnco or Zen Kashi Cancer Hospital, we have counselors dedicated for patients and separate counselors for family caregivers. So their role is just to listen to them, understanding what they are going through, and just be there for them. And we have seen that patients. They feel a lot better, a lot, they feel good about that somebody is there for us to listen to, understanding our pain. They do understand what challenges we are going through. It really helps them in going through the treatment phase. And also we should more focus on caring for the caregivers, so caregiver support system, because they are the backbone of the whole cancer treatment. They are the one going through the everything, managing finances, taking care of the patients, their medications, all of those things they take care of for the patients. So I think they get exhausted managing everything. So providing emotional comfort and support to them actually improves outcome for the patients too, because then they don't create or show that frustration to patients, or they're able to manage patients better. And there are many evidence backed integrative care therapies such as pain management, symptom control, yoga, ayurvedic support, where appropriate in approved by oncologists, because there are many places we have seen that some random ayurvedic medicines are given which actually is harmful and adds more toxicity. So it's important that what you take in, you should know that what you are eating, so it improves overall quality of life significantly for the patient. So I think that closing the survival gap requires not just the better treatment protocol, but also full ecosystem of supportive care, especially in rare cancer like BTCs, where families are completely lost in terms of not just the medical treatment, but how to even navigate through this journey completely.
Right. That is much as needed. I think the financial burden is something which requires support and guidance as well. Dr. Madan Gopal, what role can government initiatives such as Ayushman Bharat, cancer registries, public-private partnership, and national cancer control programs play in reducing the survival gap in biliary tract cancers? And are there specific policy interventions you would recommend?
So it's already things are in already place. But as you have asked that, okay, what can be recommended? Because if you talk about the national program for non-communicable disease, the cancer screening is in a big way. If you talk about the policy, that means last year there was a budget announcement for having a daycare cancer center, which would be acting as a spokes for the referral hospital. That means the tertiary level hospitals. But apart from doing all these things, if you talk about the other schemes which are there, the Ayushman Bharat PMJ program, there are also a lot of procedures are there, packages are there. But see that how it can do. But what the government can do for reducing the survival gap, I think it should be acting on three levers. One is early suspicion and referral. That's the key. We do have a network of the many Ayushman Arogya Kendras there through a checklist and other some initial screening happens. That is it's essentially restricted to the high visible, that means oral, cervical, and the breast cancers. It is focusing on that. But see that how that lever which is available that can be utilized for having, because biliary tract cancers are very difficult because there is no common screening protocol. How it can be easily screened at a mass level or community level. That's one thing. Second thing is we need to have assured diagnostic. Though the policy implementation is that after the COVID, we have invested a lot into the this integrated public health laboratory. That means taking the diagnostic near to the hospital, which are assured level of care, with a referral protocol between that integrated public health laboratories and the medical colleges. Besides that, if you talk about the uh, other thing, that means a multi disciplinary team, the tumor boards which you usually call, that mechanism is also been promoted and been pushed to the PMJ scheme and other things. Besides that, you have already seen that the Pradhan Mantri Jan Arogya Yojana is there. It is meant for in-service patients, and cancer treatment is one of the important pillars of that. So as to provide financial protection to this is the third pillar, I think, and fourth one is to have an identifier, a unique identifier to the patient, so that a registry development is also happening. If you talk about Ayushman Bharat PMJ scheme, uh, some biliary tract procedures are there. ECRP is already there because I was involved with the health insurance scheme earlier. And in fact, the HBO 1.0 package, when the scheme was launched, the ECRP and the stenting was there. The bile duct surgery was already there. The chemotherapy and other things are always been part of that. Now, with the evolution, I think if new things are being added to that, I think that's the area where we can clearly define packages for this biliary tract cancer. Second thing is we have to see that how the hospitals which are there, their quality of employment can improve, so that we can strengthen the hospital and the network which is there. We have to ensure the empaneled centers have the multidisciplinary team based for this hepatobiliary oncology care, and they having a formal referral linkages, so that they can tie up with the take care cancer centers and they can utilize that pathways which we are trying to evolve. The whole purpose of this treatment is to reduce the catastrophe expenses, as well as reduce the as well as the rationalizing the packages and the other paraphernalia associated with that. We
Right.
Another thing is we have to improve the capturing of the data which is for the gallbladder and the uh, cholangiotic carcinoma, ampullary region, as well as record the stage at which the diagnosis happens. The registry can be used for identifying the hospitals, hotspots, and tailor local strategies for that. But besides that, the referral pathways and the time-bound care is also one of the area where the government is focusing on. We're trying to introduce the standard referral triggers for primary and secondary care, so that the obstructive jaundice, unexplained weight loss, and persistent pain can be always taken care of. Some time targets can be set so that the suspicion to diagnosis, the turnaround time with a multidisciplinary team plan, at least some timelines can be different for this. Besides that, for addressing all these three levers, we require a good partnership between all the providers. We usually use the term of public-private partnership, but we have to say that we should be having partnership for provisioning of this care, so that we can help in establishing regional multidisciplinary team hubs, which can be linked to the district hospital, medical colleges, as well as we can use the tele-oncology, which is now this for the treatment planning, reducing the repeated level. We do have good examples. We say that how the tele-oncology is working, how they have been able to manage the hub and spoke models, so that another thing which we are trying to invest is see that how we can improve the access to molecular testing, so that the targeted therapies and other things, uh, uh, other modalities for transplant eligibility can happen, so that proper audit can also happen. This we do have a national cancer program, so that how we can integrate the NCD clinics which are there to identify the BTC within this ambit. And besides that, the medical college strengthening is also there. The capacity for the medical colleges are also to be created, uh, so that we can do that. So, in nutshell, we can say that we do have to create BTC critical pathways. We have to assure diagnostics, though we would be having network of integrated public health laboratories. Besides that, beside laboratories, when we are having daycare cancer center, the hubs which would be the hubs would be uh, we should be having MDT in the hubs which would be catering to the daycare cancer center. Work on the ABPMJ packages to include more robust kind of BTC packages so that financial catastrophe is there. Besides that, use of ABHA and the ER for this. One of the important gains which will be coming about making the BTC a pathway-led disease will result in faster suspicion, fast diagnostic, multidisciplinary team care, as well as financial protection. So this is all the things I think if BTC is made into the main thought process, I think these benefits would be there. Thank you.
Right, right. And Dr. Prasad, since you are a clinician and you have addressed this fact earlier also that these are the rare cancers which require, I think, awareness and early diagnosis. So I would like to ask you that in a resource limited setting, which biomarker or screening tool can help us pick up these rare cancers?
I don't think there's a screening tool. So, as Sushant said, it should be part of the usual health check package that we do, because there are no one screening tool for biliary tract cancer. But having a high index of suspicion, not ignoring the early signs, not if symptoms are not getting improved with the usual medications, should raise a red flag. That is the primary thing. And also there are some blood markers, but they are not diagnostic of biliary tract cancer. So I will not say there's a screening tool, but I think awareness about the existence of these malignancies and the fact that when diagnosed early there can be a much improved outcome is the key here.
Right. So, since there is no early detection tool, I think we have to close the survival gap and it is much needed. So, to all the panelists, last question would be to truly close this survival gap in biliary tract cancers, what is the one change that we require, whether it's a clinical, systemic, or policy driven, that must happen in next 3 to 5 years? So, let's start with Dr. Sushant.
Ma'am, I think not only the allopathic doctors, but our colleagues in different branches like in Ayush, in Ayurvedic, homeopathy, Tibetan, Unani, they should also have these regular CMEs and upgradation in knowledge, and to make aware that it should be an integrated approach. One is not better than the other, but in these scenarios, one might be required in acute stages, the other signs may be required in the other stages of the treatment, so that and we should also take care of the quacks who misguide such patients. Then only we'll be able to diagnose them at an early stage and fill these gaps.
And Dr. Aditya, what do you think that there should be a major change, whether it's a clinical, systemic, or policy driven?
I think this was briefly highlighted by Dr. Prasad earlier. In the clinician's mindset itself, the change should come that biliary tract cancers are treatable. The survival can be improved. There are plenty of low cost, accessible molecular testing platforms available. We need to utilize these platforms. And there is also improved access to newer molecules like immunotherapy, especially in India for the middle class population. And we must embrace technology to try and improve the outcome. What we should not resign ourselves that, Are, ye to stage 4 hai, anyways, they are not going to make it. I think the new mantra should be that small increments will lead to large difference for even an individual patient.
That since we do not have any diagnostic tool, we which can pick it up, early diagnostic screening tests. So I think the suspicion is something which we should bank upon, and we definitely require, molecular testing and genomic testing here, because these are the things which will help us to target the cancer better and treat the cases which we pick up. Dimple, anything you want to add from your end?
I think most of it is already covered, but just to summarize, I think to close the survival gap in BTC, the most urgent change probably since we know that the early diagnosis may not be possible, but we can certainly build integrative care pathway around this, which is early referring patients to the right specialist. Most of the time we see that patients, their family doctors or whoever is closer to their home, they treat it as per the initial symptoms of maybe jaundice or some other issue, but referring patient timely to the specialist may be able to make a significant difference. And like doctor mentioned, molecular testing access and strong supportive care, so that patients are not alone navigating through this entire process, while they have a very structured supportive care team in hospital, in a home, counseling team with them, and also integrative care, so that they're able to tolerate the therapies, tolerate the treatment process better, and which improves their quality of life, and overall it improves their treatment outcomes and survival as well. So having integrated care of medical, molecular testing, everything else, along with it, the integrative oncology system will definitely make their life easy, journey better, and also improving clinical outcomes.
Right, I think integrative care wherein their emotional support, financial support, and nutrition and other things are also taken care of. These things are required definitely in the system. Dr. Prasad, your last word on this, that to truly close the survival gap for biliary tract cancer, what is one change, clinical system or policy driven, that must
I think,
happen in the next 3 years?
you can't say one change in this, as you say, but probably having a point of care ultrasound. If you are, since we talk too much about the cancer, the screening, which is a very, very affordable screening tool, especially if you just make it like a high risk screening tool in the gangetic belt, or more than 40 years, or people who have history of gallstones. Probably that would be the thing, because whatever we do, unless we diagnose more than 75% of the cancers in early stage, we are not going to make a paradigm shift in the outcome.
Right. I think early detection is what is required for most of the cancer, and for certain cancers which are widely talked about and which where we have the early screening, they have really fared well. Cervical cancer or breast cancer, and this is one cancer, the biliary tract cancer, where we require not only the awareness but also point of care ultrasound, as Dr. Prasad has said, and integrative care, as Dimple has emphasized. And other panelists are also emphasize that this is something which presents late. So we have to have, the clinicians have to have, the suspicion, and patients definitely need to have the awareness that if they face any jaundice or any, dyspepsia, which they are treating with, over the counter proton pump inhibitors, they should definitely not do that and get themselves investigated from the proper oncologists or doctors, because it may be something else which has not been picked up. So with that note, I thank you all for joining us today and giving your insights and creating awareness. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Much. Thank you.